but just that facial expression tells you a number of things. So I want us to look at the types of pain. I want us to look at the types of pain, and one of the types of pain is nociceptive pain. One of the types of pain is called nociceptive pain. So nociceptive pain is divided into two. We have what is called somatic and visceral pain, which is coming from tissue injury or inflammation. So this nociceptive pain to appreciate the part of neuropathic injury. You can be able to appreciate the part of neuropathic injury. So apart from that, I want you to know that we have what is called referred pain. We have referred pain. Referred pain is the pain that is felt at a particular site from the different source. We will be able to understand more on what we mean, that this pain is being felt at this particular site, but it is not being felt from the source of pain. The site where the pain is coming from and the source of pain, they are totally different. That is what we're trying to say if we say from the site of pain. That's what we mean when we say referred pain. So the part that is paining is not the part that is affected. In short, the pain is referred to the part that is not affected. So the part that is not affected is paining, while the pain is coming from somewhere else. More details will be given on this. We also have what is called the psychogenic pain or functional pain. Psychogenic pain, this is influenced by psychological factors. Sometimes this can be anxiety, depression, emotional trauma, something like a heartbreak. Someone will tell you heartbreak is painful. What is something that is painful between? Maybe they will tell you labor and heartbreak, then you begin to compare. But these types of pain are totally different. I want you to know that. Then, according to duration, you can have acute pain as well as chronic pain. Acute pain is this pain that has started within the short period of time, and the duration is short. It will not take a long time. It is going to stop. It might be severe, it might be so painful, but the thing is it will not take a long time because it has just started. So you can't say you can say this is acute pain because it has the short duration, but you can't see it has a short onset. It has a short, let me say, it has an immediate onset, but you can't say this is, you can't conclude that this is acute pain when time is passing. Depending on how long has passed, if it goes to greater than 3 months, then this pain will begin to call it chronic pain. For those of you who have just joined watching on YouTube, I want you to know that because of network, it is so harsh to share the screen, so I've decided to just play a bit of audio so that you can be able to learn something while the record will be coming through, so that you can still get the screen. So the record of the screen is coming, but for now you are going to get a bit of audio. If you have any question, you have anything that you want to find out, you can still ask in the group and I'll be able to attend to that. The other part that I want you to understand is that we have what we call, so for now let's get a bit into the details of what I told you. We talked about types of pain, and now I want us to get into the details. When we talked about nociceptive pain, I told you that nociceptive pain can be divided into somatic as well as visceral pain. Now I just want to break down somatic pain. It's very important. If you are in, I want you to stick around so that you can understand one or two things. Somatic pain is the pain that is coming from, number one, the skin, from muscles, from joints, as well as bones. Somatic pain is the pain that is coming from the skin, hope you are writing, muscles, joints, as well as the bones. So this pain is well localized. It's very easy to say this is the part that is paining. That is what I mean when I say the character of this pain is that it is well localized. The other part is that it is sharp and aching or throbbing. That's another part, and that's another character of this pain. Please do not be upset if the patient fails to localize the pain, because the only type of pain that is localized in this case is somatic pain, because it's coming from these structures that we've mentioned. The other type of pain is visceral pain. Visceral pain is coming from internal organs of the body that are stretching or going through ischemia. Sometimes it is poorly localized, which means the patient will not know where the pain is. They will just be pointing randomly, this side, the other side, poorly localized. Then the other part that we should understand on the differentials of this pain is that some of the differentials we should suspect are appendicitis, bowel obstruction, biliary colic, and renal colic. They are some of the differentials that we should know. Then for somatic pain, some differentials are fractures, arthritis, muscle strain, as well as cellulitis. They are going to present with somatic pain. This is the pain that is localized because it is coming from the skin, the muscles, the joints, as well as the bones. So go. For those of you who are able to see the screen, I know that some of you are not able to, and I want you to hold on, understand one or two things, because the screen will appear as soon as possible just because of network. We have what is called neuropathic. I've already talked about that. And we have somatic as well as visceral. So let's talk about referred pain. So I said referred pain, this is the pain that is perceived at a site distant from the actual pathology due to shared spinal pathways. So these sites, they have common spinal pathways because they have common nerves. When this pain goes to coming from a particular site, it is interpreted by the brain as if it's coming from another site. For example, right shoulder pain in gallbladder disease. It's coming in because of what we are calling referred pain. So don't just be shadowed with where the patient is pointing. Don't just focus on where the patient is pointing. If somebody is saying my right shoulder is paining, don't just focus on the right shoulder. Sometimes right shoulder pain can mean gallbladder disease because of referred pain. Left arm or jaw pain might mean myocardial ischemia. Myocardial ischemia will present with left arm or jaw pain. Why? Because that is referred pain. There is more reasons behind that. There's more reasons that have to do with nerves, but because of time, if you have any question you can ask, I'll be able to explain. Back pain coming as a result of pancreatitis or abdominal aortic pathology. We are all trying to talk about one and the same thing because they have a shared neural pathway. Thank you so much. Let's continue. We also have what is called neuropathic pain. This is caused by nerve injury or abnormal nerve signaling. If the nerves have started misbehaving, they think there is pain where there is no pain. That is called abnormal nerve signaling. Then we can also have nerve injury, something that we can have in diabetic retinopathy. Let me say diabetic neuropathy, not retinopathy, neuropathy. We can have nerve injury in diabetic neuropathy. Hypertension can bring about nerve injury. So that is called hypertensive neuropathy. So this is what can bring neuropathic pain. So character of this pain can be burning in nature, electric shock or shooting, tingling, or pins and needles. This is what you understand, and this is what you find out in patients that are suffering from diabetes, because they will tell you, I feel like I'm feeling like pins and needles under my foot. That is what is called neuropathic pain. So Some of the differentials of neuropathic pain I've already mentioned. The diabetic neuropathy. Another one is post-hepatic neuralgia, as well as radiculopathy and stroke-related pain. Those are the differentials of neuropathic pain. So the pain that is felt in that is called the neuropathic. I just want us to go through a bit of the pathophysiology. I know it's not everyone who likes the pathophysiology, but I want you to understand me. I like the pathophysiology because it helps you understand why things are coming in and how you can come in to intervene. So I want you to know, if you are able to see the screen, I want you to know that picture that we saw in grade 12 of someone being pinched or someone experiencing a pain on the finger, and the pain begins to go. We have relay neurons and motor neurons. I want to assume that we can be able to understand such. So I want to focus so much on the chemical side of what is happening. There is what are called, when there is that injury, there is going to start what is called inflammation. For that inflammatory process to start, there are what we call inflammatory mediators. Some of the inflammatory mediators that we have is histamine. We have prostaglandin, which is so much sensitive when it comes to transduction. This is where the mechanical, the thermal, or the chemical signal that is causing your pain is being converted from that level to the electrical signals. So it's being transmitted in the nerves as electrical impulse. So it's being transmitted. If it was pain from the slap, that slap is going to be converted to electrical impulses so that it can be passed through peripheral nororeceptors. That is called the transduction. The second of you might not have heard this, but I want you to trust me. This is very important and it is helpful because it can help you to intervene in case your patient is having pain, in case your relative is having pain. You can know what you can do. Another part of the 4 core processes of pain is modulation. The nerve system alters the pain signal. Since you've already done something about it, so the nerve system will begin to alter the signal. This is the part where you have some mechanisms that will help you adapt to the pain. Some hormones like endorphin, serotonin, that will help you to let you know there is this pain somewhere there and all that kind of stuff. Something that will help you to moderate the pain. And you are going to have what is called relieving as well as alleviating factors. Something that will relieve the pain. You are going to come up with them because of the modulation system. So this modulation system will either inhibit the pathway or will help you to find mechanisms that will help you make the pain feel better. Then we also have perception. The perception point, this is where now the conscious interpretation of pain which occurs in the brain and integrating sensory and emotion cognitive aspect. So the first part of pain, when the pain is just there, you reply or you respond to the pain before it even reaches the brain. It is interpreted and the relay neuron, motor neuron, everything happens just at the level of the spinal cord. After that, modulation takes place. That's when you perceive the pain. That's when you can explain the pain. That's when you can say things about the pain because it's now interpreted, it's now perceived by the brain. That is what we are doing. So most of the ways that we use to, maybe those people that we respect so much in theaters, anesthesiologists, they are going to tamper with the transmission of pain. And we know all the pain that we feel from all the other parts of the body can be transmitted through nerves. So there is what is called nerve block. We are going to block a particular local blocking where you just block this particular site where you want to work from. For example, when performing what is called a male circumcision, you are just going to perform a nerve block. You are not going to do it at the level of the regional or the spinal cord, because you are just dealing with one part. So we're trying to see that the management of pain tries to follow these steps that I've told you. Number 1, transduction. Number 2, transmission. Number 3, we have modulation. And number 4, perception. Sometimes you just deal with the perception of pain. The pain is there, but the mind, the perception is dealt with. Some people that have taken alcohol, they have little perception of pain, no matter how the transmission can be going to the brain, but they can't perceive the pain. So the connection is unstable due to network. Hope you are able to hear me, but if you are able to hear me, even when you can't see the screen, I request that you stay a bit so that we can see how we can make things work better. But the screen will come in soon. I'm trying to make sure everything goes well by using all possibilities. We are recording so that even when you haven't seen the screen, you can still follow through and be able to see the screen later. So there is also what is called the cramping pain. Then there's also what is called burning pain. Burning is usually seen in what I said, neuropathic pain and other reflux diseases. Then we have pressure or squeezing pain that comes in ischemic, that can also be called in ischemic pain in angina pectoralis. Angina pectoralis is going to present with what is called squeezing pain, or can present with a burning sensation. Alright, pain intensity, that's what I want to talk about next. Pain intensity or pattern. The intensity of pain can be mild, moderate, severe, but we use the scale of 1 to 10 because there is no painometer. I'm not insulting, I'm just trying to say there is no meter that will help you to measure the pain in the patient. Pain is subjective, we depend on what the patient will say. So we are going to ask them, on the scale of 1 to 10, how can you rate your pain? That is intensity. So temporal, there are pains that have patterns, and I want you to know pain as the pattern. When you are trying to look at pain, it has the pattern. So we have temporal pattern. We can have constant, or we can have intermittent, we can have episodic, and we can have progressive. Recently I was meeting the patient who told me they have what is called the pain that comes at times. It's called episodic pain. We are talking about pain in the lungs. We're trying to talk about maybe by food, we're trying to talk about pain that has to do with PUD. We have gastric ulcer, and we have duodenal ulcer. Those things we have to understand. Then we also have relieving factors, some of which are rest, medications, position, heat or cold. Some people, they will say when I put ice on it, it stops. Some people will say when I put warm water on it, it is at least better. So we have to understand relieving factors when it comes to pain intensity and patterns. Hope we are moving together, trying to see how we can catch up. Having done that, I want to mention a few of differentials. Some of the differentials, in case you have what is called the chest pain. This is pain in the chest. Think about acute coronary syndrome. Think about pneumonia. Think about pulmonary embolism. Think about obstruction. This is called intestinal obstruction or UTI. It is going to present with abdominal pain. So should have high index of suspicion and be able to start ruling out these kind of issues. Peptic ulcers, think about those. Then somebody presents with headache, think about tension, migraine, or begin to think about issues to do with meningitis, think about hypertension, think about hemorrhage. There is also something that is called intracranial hemorrhage. Think about intracranial hemorrhage or raised cerebral spinal fluid is what you should think about. Somebody complains of back pain, think about muscle strain, think about renal pathologies. Alright, having that said, I want to look at the knowing the site. Where is the pain? It's here. Is it moving? Is it something like that? So, onset. When did it start? And did it just suddenly start, or it has been coming gradual? Ask about that question so that you know about the pain. If it's the sudden pain and you know the severity of sudden pains. Gradual pains, you know what can cause gradual pains. Gradual pains can come as a result of malignance. Sudden pains can come as a result of ischemia or other urgent, or let me say acute conditions. Then think about the character. Ask about the character. Is it sharp? Is it dull? Is it burning? Is it throbbing? Is it cramping? And we've already talked about how sharp pain can come and what can cause that pain to be sharp. Some part of the body is undergoing ischemia. We talked about the origin of this pain. I said somatic as well as visceral pain. So it could be coming from a muscle, it can be coming from the bone, it can be coming from the skin, or this dull pain can be coming from an internal organ that is stretching. So we should think about that. Depending on what the area they have pointed, you should think about what organ is under this skin. If they are saying there is dull pain, you should be able to try to suspect that kind of an organ, to say it is going through some kind of stretch, and be able to come up with differentials. Then we talk about A. A is associations. This pain associated with any symptoms, any other symptoms associated with this pain. It can be associated with nausea, it can be associated with fever, sweating, or any weakness. You should be able to ask about that. The other part is timing. Is it constant or intermittent? Timing can go together with pattern. I've already mentioned about the pattern and the duration. You can still ask about it here. You can ask about exacerbating as well as exacerbating and relieving factors. Ask about that. What makes it worse or what makes it better? They will tell you the things that I mentioned on exacerbating as well as the relieving factors. They will ask about the severity. On the scale of 0 to 10, how do you rate your pain? What triggers the pain? Then Q is what quality. What does the pain feel like? On quality, we're also trying to ask about character. If we ask what does the pain feel like, someone will begin to give the characteristics of pain. So in Socrates, quality is also called the character. Then R, the region or radiation. So we can talk about region, where is the pain, and does it radiate? What we're asking about on site in PQRST, we're asking it on R, to say region as well as radiation, region as well as radiation. Then S is severity. One of the red flags is suggesting to the patient, are you having throbbing pain? Are you having crushing pain? Or maybe are you having this kind of pain? Then the patient is in pain. They will just be accepting everything. Then you will make your own diagnosis. That is not going to help the patient. So another red flag is pain associated with shock signs. That's why we know associated factors. If you have hypotension, somebody has pain and hypotension, it's a red flag. It means you are dealing with an emergency. Someone has pain and there is tachycardia. You need to be in a hurry because you have no time. Someone has pain and there is altered mental status. If this pain is headache, begin to think about meningitis, please. Your patient is dying. Alright. Chest pain with dyspnea or diaphoresis, begin to rush. Abdominal pain with gagging, rigidity, or persistent vomiting, you are in trouble. Then neurological deficit with headache and back pain, please, you are dealing with an emergency. So I know there is what is called malingering. I know other people can fake pain, but I want you to understand how real pain is. When somebody has real pain, you can try to play around with rebound tenderness. You can try to play around with tenderness, especially if it's on the abdomen. They will not fake tenderness. All right, we go. So a key clinical message that I want to give to every one of you is that pain is a symptom and a diagnostic clue, not just a complaint. Don't just think people maybe trying to just say things that are not there because you can't feel the pain. You can just see someone touching a region. Don't just take it so easy. Then I want you to know people react differently when they are in pain. Be able to understand their reaction. Other people recently, a lot of health practitioners are being abused, being insulted, because people are in pain. Do not underrate, do not belittle the pain that someone is going through. Do not take it so easy that the pain is in that kind of manner. Be able to respect the feeling of the patient. So if you want to assess pain, I want you to combine the character, the location, the timing, and this is going to help guide the pain. Use the structure tools, something like PQRIST, the Socrates, and I want you to know that begin by treating the pain while you start searching for the cause and manage the cause. So the first thing is treat the pain before you manage the cause. Then at this point, I just want to appreciate you. I know that it wasn't easy, network issues, this and that, but you have at least listened and you have heard something. Thank you so much for joining us in creating expansion and excitement and worldwide. I want you to know that we are slowly by slowly trying to improve systems so that we make sure you are getting information without inconvenience. And part of the systems that we can't manage is the network, because we have no control. We can buy bundle, but we have no control on how this bundle works. So I want you to bear with us on that, and sorry for the inconvenience that it has caused. We'll try to see which other ways we can catch up so that challenges do not stop us from making progress, because challenges makes us stronger. Thank you so much. Have a fantastic night. If you have any question, feel free to comment in the group. I'll be able to reply. If your question is too long that I feel I can't type, I'll be using voice notes to explain, to make sure that you get the information that you need to get, because I will not always be where you are, and at one point I will not always be where my relatives are, but I have confidence in you because I know you will be there. You have the right information to treat people with kindness. Despite the pressure that we go through, it's not an excuse to uplift kindness on the value of human lives. And I will always say that until I see it in action. This is Patrick Nkemba, the proprietor of CFHS Zambia, and see you next week. We are going to announce in the group the next session that we are going to have, and that is obviously malaria.